Hey everyone, it's Wellness Wisdom, and welcome back to my channel, Labor and Delivery. It's one of the most incredible experiences in life, but let's be real, it can also get complicated. But don't worry, I'm here to break it all down for you. Let's review some of the complications of labor, and I promise it's not that complicated. In this video, we're going to go over what you need to know about precipitous labor, placenta previa, placental abruption, a prolapsed cord, and shoulder dystocia. Let's get started. Alright, first up, let's talk about precipitous labor. Now, you know how some labors can seem to last forever? Well, precipitous labor is the opposite. We're talking fast and furious. So first step, a very quick definition of precipitous labor. So this is labor lasting less than 3 hours from the onset of contractions to the time of birth. So think of precipitous almost like falling off of a cliff, right? The descent is really rapid. Now I know what you're thinking, Dr. Mike, that sounds kind of terrifying. And yeah, it can be intense, but here's the good news. Fortunately, most clients and newborns who experience precipitous labor do just fine as long as the baby has a soft landing. The key here is to be prepared. If you know you're at risk for a fast labor, talk to your doctor about it. That way, you can make a plan and be ready for anything. Now let's move on to some placental conditions, which are critical to understand for both expecting mothers and healthcare providers. The two main ones to know are placenta previa and placental abruption. These conditions can have significant implications for both the mother and the fetus. So, NCLEX bonus question, which concerning symptoms do these conditions share? Vaginal bleeding. This symptom is a red flag that requires immediate medical attention. Let's start with placenta previa, a condition that can be particularly challenging during pregnancy. So with placenta previa, the placenta partially or completely covers the internal cervical os. This positioning can obstruct the birth canal. And risk factors for this include multiparity, a history of uterine surgery, like a previous C-section, smoking, and multiple gestation, meaning they're pregnant with twins or triplets. These factors increase the likelihood of developing placenta previa. Now, placenta previa is typically diagnosed during pregnancy with an ultrasound, but symptoms include painless vaginal bleeding. They could possibly experience bleeding with uterine contractions, which can be alarming. Why do clients with placenta previa need to avoid active labor? This is a crucial aspect of managing the condition. There's really two big reasons. Understanding these reasons can help in managing the condition effectively. 1. Uterine contractions will cause bleeding from the placenta. This bleeding can be severe and pose a risk to both mother and baby. Remember that the placenta is highly vascular, and that can lead to hemorrhage. Hemorrhage is a serious complication that requires immediate medical intervention. And then 2, remember I said the placenta is blocking the cervix, so the fetus cannot exit vaginally. This obstruction necessitates a different approach to delivery. So that being said, how are clients with placenta previa managed? Management strategies are essential to ensure the safety of both mother and baby. Well, we definitely need to monitor for vaginal bleeding, and we want to avoid anything in the vagina. This includes avoiding vaginal exams to prevent further complications. So we're avoiding vaginal exams. This precaution helps in reducing the risk of triggering bleeding. The client needs to avoid intercourse, and if the placenta previa does not resolve during their pregnancy, a lot of times it does resolve on its own. However, if it persists, further steps are needed. But if it does not resolve and it's still blocking the cervix, that is an indication for a C-section before the onset of labor if possible, or as soon as possible once labor contractions start. This ensures a safer delivery for both mother and baby. And we have a little memory tool you can use here, PV or PREV. This mnemonic can help you remember the key points about placenta previa. So placenta previa prevents vaginal birth because the placenta is in the way. This is a critical point to remember. Alright, now let's switch on to placental abruption and what makes a placental abruption different from a previa. Understanding the differences is crucial for proper diagnosis and management. Well, with this condition, and it usually happens later in pregnancy, the placenta prematurely detaches from the uterine wall. This detachment can have serious consequences. Some risk factors for this include maternal hypertension or high blood pressure, abdominal trauma, so think violence or a motor vehicle accident, cocaine or methamphetamine use, and smoking. These factors can significantly increase the risk of placental abruption, and if you see any signs and symptoms like painful vaginal bleeding, a sudden onset of abdominal pain, a rigid abdomen on your physical exam, and a sudden abnormal fetal heart rate pattern, these are all concerning for a placental abruption. Immediate medical attention is required. And why would that fetal heart rate become abnormal? This is a key question to consider. Well, remember the baby is receiving oxygen and blood through that placenta. Any disruption can affect the baby's well-being. So if the placenta is detaching, the fetus is not going to receive enough oxygen. This can lead to fetal distress and other complications. So that being said, what do we do? Immediate action is crucial in these situations. Well, this would definitely indicate calling our healthcare provider emergently. Rapid intervention can make a significant difference. They need a rapid delivery, typically via C-section, but it can be done vaginally if they're very close to delivery, and they may be a candidate for a blood transfusion for hypovolemia if that's present. Ensuring the safety of both mother and baby is the top priority. Okay, we've talked about placental problems, which are critical to understand for the health of both the mother and the baby. Now let's review what to do for a prolapsed umbilical cord, a condition that requires immediate attention. So, this is a scary condition where the umbilical cord comes through the cervix and vagina during labor, which can be quite alarming for everyone involved. And the fetus then compresses the cord, potentially cutting off its own oxygen supply, which can lead to interrupted fetal circulation and fetal hypoxia, a dangerous condition where the baby doesn't get enough oxygen. Some risk factors for this include media group, list of risk factors for prolapsed cord, risk factors for prolapsed umbilical cord, added stock, added distribute _equally, an artificial or even a spontaneous rupture of membranes when the fetal presenting part is still high in the pelvis, which can happen unexpectedly. Or they're at a high station so the baby's head isn't fully engaged when that water breaks, increasing the risk of cord prolapse. There's also a risk factor of a non-cephalic presentation, which means the baby is not in the ideal position for birth. And what I mean by that is that the baby is not head down, which is the safest position for delivery. So maybe they're breech or they have a shoulder presenting, both of which complicate the delivery process. What are signs and symptoms of a prolapsed cord? Recognizing these early can make a huge difference. Well, definitely any visualization or palpation of the umbilical cord, which can sometimes be seen or felt. Remember, it's like grayish blue in color and ropey, a distinctive appearance that should alert you immediately. So if you see that in the vagina or at the perineum, it's a clear sign of prolapse. And again, there could be an abnormal fetal heart rate pattern, which is another critical indicator. So as a nurse, what do? Immediate action is crucial to ensure the baby's safety. We absolutely need to relieve pressure on that cord so the baby can continue to get oxygen, which is vital for its survival. So the nurse or the provider, typically if there's time, dons a sterile glove, ensuring a sterile environment to prevent infection, and uses that sterile hand to push the presenting part off the cord higher into the uterus, alleviating the pressure. And then we're absolutely calling for help, mobilizing the medical team for immediate intervention. We can also reposition the client into a knee chest position to take pressure off that cord, which can be a life-saving maneuver. We are preparing for immediate C-section delivery, which is often the safest option for both mother and baby in this situation. We can administer oxygen by mask, ensuring the mother and baby get the oxygen they need. And of course, we want to make sure that client has IV access and fluids, which are essential for stabilizing the mother during this critical time. Finally, we are going to review shoulder dystocia, a critical and often unpredictable complication during childbirth. And this is not an occupational nursing injury from holding the client's leg during the second stage of labor. Instead, it's a serious condition that requires immediate attention and intervention. What is it? Shoulder dystocia happens during that second stage of labor when the head is born, but the anterior shoulder of the baby impinges on the maternal pubis bone, preventing the birth of the rest of the body. This obstruction can lead to significant complications if not managed promptly. And why is this so dangerous? The risks associated with shoulder dystocia are numerous and can be life-threatening. Well, at this point, the neonate has minimal access to oxygen due to impaired placental circulation, which can quickly lead to severe complications. But they also can't take a breath yet because the torso's not born and the chest can't expand. This inability to breathe can escalate the situation rapidly, and so this can cause hypoxia, which can be very, very dangerous. Hypoxia, or lack of oxygen, can lead to long-term neurological damage or even death if not resolved quickly. And it also causes physical injuries to both the parent and the neonate. The physical strain on both parties can be immense. There can be maternal soft tissue lacerations and pelvic injury, which can lead to significant postpartum complications and prolonged recovery. And the neonate can have a brachial plexus injury, a broken humerus, which can affect the baby's mobility and development, and even a broken clavicle from trying to deliver the baby past this dystocia. These injuries can have lasting impacts on the child's health. What are a few risk factors for shoulder dystocia? Understanding these can help in anticipating and managing the condition. Some big ones to know is that frequently there are actually no risk factors present. This unpredictability makes it a challenging condition to prepare for. It can be completely unpredictable, occurring even in seemingly low-risk pregnancies. But gestational diabetes and fetal macrosomia are two known risk factors. These conditions can increase the likelihood of shoulder dystocia. And what is fetal macrosomia? This term refers to a condition where the fetus grows larger than expected for the gestational age, making delivery more difficult. Well, this is when the fetus grows larger than expected for the gestational age. Larger babies can have more difficulty navigating the birth canal. Alright, so we're in a shoulder dystocia. What do we do as nurses? Immediate and effective action is crucial. What do we do as nurses? Teamwork and communication are key. Every second counts in these situations. Teamwork and communication are key. The provider will notify the nurse of the presence of a shoulder dystocia emergency. We're going to stay calm. The provider will notify the nurse of the presence of a shoulder dystocia emergency. We're going to stay calm. Call for additional nursing and provider help. Call for additional nursing and provider help. Quick and coordinated efforts can make a significant difference. Then we want to apply suprapubic pressure to release the impinged anterior shoulder. This technique can help free the shoulder and facilitate delivery. And there's something called the Mack-Roberts maneuver. Do you remember what that is? This maneuver is a critical technique in managing shoulder dystocia. Do you remember what that is? Well, that's when we do hyperflexion of the client's legs to their abdomen to try and increase the pelvic diameter and give the baby a little more room. That's when we do hyperflexion of the client's legs to their abdomen to try and increase the pelvic diameter and give the baby a little more room. This can often help in resolving the dystocia. And there's also the Gaskin maneuver, which is putting them in a hands and knees position. This position change can sometimes help in dislodging the shoulder, which is putting them in a hands and knees position. This maneuver can be particularly effective in certain cases. And of course, we want to remain calm and explain to the client or the family what is happening. Clear communication can help in managing the stress and anxiety of the situation. Teamwork always makes the dream work. In these critical moments, a well-coordinated team can make all the difference in ensuring a safe delivery for both the mother and the baby. And there you have it. Labor complications demystified. We're finished with labor complications. And woo, I know that was a lot, but you did wonderfully. Remember, knowledge is power, and being informed can make all the difference. I will see you in our next maternity video.